Of course, taking a very careful medical and medication history is important first to identify who might have either primary or secondary immunocompromising situations, identify the severity of the immunocompromising condition or medication that they might be taking, and to verify their vaccination history. We've sort of built in these questions now in all of our, primary care and in our specialty care, whatever EHR that you might use, sort of algorithms to make sure the questions about vaccination for COVID are incorporated into that, and to discuss the use of preventative measures such as mask wearing and social distancing.
So the question, are there additional measures to identify who's still at risk? Since checking spike antibodies is not currently recommended, Roger, we talked a little bit about this, and that a lot of people jump to this as the answer to all of our problems.
Yeah, and in fact, I like the fact that it's no longer recommended, because it like you said earlier, it led to a false sense of security for some, and some unnecessary scare to others. We have two branches of the immune system, the humoral and the cell-mediated. We're measuring one, and the measures vary in their specificity and sensitivity in telling what your clinical susceptibility really is. So it's important that we first just tell people that it is a graduated risk. Age is a big risk factor, so are many others. Immunosuppression, like you saw the different types of immunosuppressive conditions, that they actually have different impact on your responsiveness to the vaccine. So all that is important too. I know people don't like nuanced messages. They like, but we have to tell them that the situation is a little more nuanced than they would like it to be.
And we risk losing credibility if we pretend it's anything but that. And
we've already lost it.
Yeah. I do think that's part of it, right? People have difficulties dealing with nuanced messages, but we just need to spend a little extra time.
So here is the updated COVID-19 vaccine recommendations for immunocompromised patients, and this was actually just updated 5 days ago by the CDC with the approval of protein-based vaccination for immunocompromised individuals in the new variant era. So this is also on the CDC website, and October 6th is the latest update. So for patients that are immunocompromised over the age of 12, there's additional tables for pediatric population as well. But over the age of 12, if a patient is unvaccinated, then it's recommended that they get 3 doses of an mRNA-based vaccine or 2 doses of a protein vaccine. If a patient has already been vaccinated with 1 or 2 doses of an mRNA vaccine, then they would either get 2 and 1 dose of an mRNA vaccine, so that they end up with 3 doses, and the 3rd dose, the subsequent doses, would be the monovalent updated vaccine from the same manufacturer. If a patient has already had their 3 doses of an mRNA vaccine, they still get an updated dose with the monovalent mRNA vaccine. However, if they've received a vaccination schedule that includes an adenoviral-based vaccine or a protein-based vaccine, with or without an mRNA-based vaccine, they can get an updated booster with either a protein or an mRNA vaccine. So if you're in these situations, I recommend that you go to the CDC website and pull up this table again, because A, it's changing, and there's just some subtleties that I don't try to keep to memory. But
and there's another table for the non-immunocompromised.
That's right.
So
that's right.
There's a lot to review.
Yeah, so it's not identical to the non-immunocompromised. So I do recommend that you do that. When you do get a booster, the recommendation is to wait at least 2 months from the prior vaccine to get the new monovalent vaccine. Now, vaccination timing is one of the few areas where I think that I still get calls from as an ID consult in terms of when to vaccinate patients that are about to undergo chemotherapy or stem cell transplant or CAR T cell therapy. So ideally, if you have the luxury of time, you don't always have that. Vaccination should occur 2 weeks before the initiation of chemotherapy. In a patient that's undergoing CAR T cell therapy or stem cell transplant, the recommendations are to vaccinate 3 months after CAR T cell therapy. And in someone undergoing intensive chemotherapy or for a hematologic malignancy is to wait until there is cell count recovery. I will also say in these settings, the question of revaccination comes up as well. And so particularly in patients that have received their vaccination series pre or during their CAR T cell or stem cell transplantation, the recommendations are to restart that vaccination afterwards. For solid organ transplants, ideally you would vaccinate prior to transplant, at least 2 weeks prior to transplant, but if that window unfortunately is missed, to wait a month after transplant before vaccinating, knowing that even in that short window though there's going to be more immunocompromised, so the boosters become really critical. And in those that are initiating or resuming immunosuppressive therapies, again, 2 weeks before initiating them. There's one situation which is in B-cell depleting therapies for folks that are on them chronically for rheumatologic conditions. The recommendations are actually to vaccinate at least 4 weeks prior to the next dose of a B-cell depleting therapy. So these are patients that are having ongoing B-cell depleting therapy.